Hello, my name is Amartya Chatterjee and I am one of your tutors in Make Medical Easy. I will be teaching you the pharmacology part of the cardiovascular system. Before continuing this video, I would like you to check out our other videos taught by my colleagues. Now, CVS can be divided into four main parts. Those are anti-anginal drugs, antihypertensive drugs, antiarrhythmic drugs, and the last one, drugs on congestive cardiac failure. Now, today our discussion is broadly based on antihypertensive drugs. Now, before going to the pharmacology part of hypertension, I would like you to know what is hypertension. Hypertension is blood pressure more than 40 by 90 millimeter of mercury. Normal should range between 120 to 80. Prehypertension ranges between 120 to 39 systolic blood pressure, that is, and diastolic blood pressure should range between 80 to 89 for prehypertension. And the main hypertension can be divided into two stages. Stage 1 is when the blood pressure, systolic blood pressure ranges between 140 to 159 and diastolic blood pressure ranges between 90 to 99. And the stage 2 of hypertension when it is more than 160 systolic blood pressure and more than 100 diastolic blood pressure. Now, what are the causes of hypertension? Now, the causes of primary hypertension can be included hyperlipidemia, diabetes, genetic, family history, race, age, obesity, most importantly, stressful lifestyle, and cigarette smoking. Now, secondary hypertension can be linked with renal artery constriction, coarctation of aorta, pheochromocytoma, Cushing disease, and some kind of drugs. Now, treatment of hypertension can be divided into two main parts. The first part is non-pharmacological part, like quitting cigarette smoking, doing regular exercise, restricting dietary intake of salt mainly, saturated fats, and calories. Now, before discussing the drugs of antihypertensive drugs, I would like to discuss the pharmacology of how hypertension or how normal blood pressure is controlled in our body. Like, always remember this formula. This is an arterial blood pressure equal to cardiac output and peripheral resistance. Now, cardiac output can be influenced by heart rate, contractility, filling pressure, that is both blood volume and venous tone, and peripheral resistance is mainly controlled by arterial volume. Now, if any of these factors like heart rate, contractility, filling pressure, or blood volume or arterial volume can be controlled, then our blood pressure can be increased or decreased. Now, I would like you to check out the mechanism of controlling blood pressure. Like, whenever there is a decrease in our blood pressure in our body, our sympathetic activity increases in our body. Like, if sympathetic activity increases, the activation of beta 2 androgen receptors on the heart. Now, whenever there is decrease in blood pressure, our sympathetic activity increases. And when sympathetic activity increases, there will be activation of beta 1 adrenal receptors on our heart, activation of alpha 1 adrenal receptors on the smooth muscle, and activation of beta 1 adrenal receptors on kidney. Now, activation of beta adrenal receptors on heart will increase the output. Alpha 1 adrenal receptor will increase the venous return, and beta 1 adrenal receptors on kidney will increase renin, which we will study sometime later, and also increase the peripheral resistance. Now, alone sympathetic activity can increase this amount of blood pressure. Now, whenever there is decrease in blood pressure, our kidneys also respond, because as you can see, there are also beta 1 receptors on kidney. The beta 1 receptors increase the renin factor. Now renin in turn increases angiotensinogen 2, and angiotensinogen 2 will increase aldosterone, and aldosterone will increase sodium water retention, blood volume, and decrease glomerular filtration rate and renal blood flow, which all of these factors will again increase the blood pressure in our body. Now, our cardiovascular drugs of antihypertensive drugs can be divided into three main parts. These are diuretics, renin angiotensin system inhibitors, sympathetic inhibitors. I would like you to remember this chart very vividly. This comes in the exam. Now, under diuretics, we have thiazides, high ceiling diuretics, and potassium sparing diuretics. In renin angiotensin system inhibitors, we have angiotensinogen converting enzyme inhibitor, which helps in conversion of angiotensin 1 to angiotensin 2. Angiotensin 1 receptor blockers, direct renin inhibitor. In sympathetic inhibitors, we can divide it into four parts, and these are beta adrenergic blockers, alpha plus beta adrenergic blockers, alpha adrenergic blockers, and central sympatholytics. As you can see, the centrally acting sympatholytics acts on the vasomotor complex in our brain and helps us to decrease the blood pressure. Alpha blockers, vasodilators, calcium channel blockers, angiotensin receptor blockers, AC inhibitors act on the blood vessels, heart, and also on the kidney. Renin, as you can see, is acting on the kidney, and aliskiren, which you can see there is only one drug under renin inhibitor, acts on decreasing the renin, and that in turn decreases angiotensinogen to angiotensinogen 1, angiotensinogen 2. And as you can see, ACE inhibitors, they are helping in decreasing the conversion of angiotensinogen 1 to angiotensinogen 2, and in turn is decreasing our blood pressure. Now our first discussion will be about angiotensinogen converting enzyme inhibitors. Now first I will like you to know about the physiology of how angiotensinogen works. Now you can see angiotensinogen is there in the kidney. Now renin from kidney activates angiotensinogen to angiotensinogen 1, which is an inactive stage. Now angiotensinogen converting enzyme activates angiotensinogen 2. Now these AC inhibitors act on this angiotensinogen converting enzyme and decreases it. This leads to decreasing of angiotensinogen 2. And as angiotensinogen 2 is decreased, there will be decrease in output of sympathetic nervous system, increase of vasodilation of vascular smooth muscles, decrease in retention of sodium and water, and increase in levels of bradykinin, which all of those factors, when summed up, decreases our blood pressure and thus decreases our hypertension. Now, among other things, we can see when we have renin inhibitors like aliskiren, we can see that angiotensinogen 2, which is in our blood, will not get converted to angiotensin 1. And again, when we have AC inhibitors, which acts on angiotensin converting enzyme, we will see angiotensin 1 will not convert to angiotensin 2. And when we have angiotensin receptor blockers, we can see angiotensin 2 will not even be received on the kidney, and aldosterone production will also decrease, which will again lead to decrease in output of sympathetic nervous system, increase of vasodilation of vascular smooth muscles, and decrease in retention of sodium and water, which again will lead to decrease in blood pressure. Now again I will like you to, because this picture you need to fully memorize in your mind, and all if you can remember this mechanism, You can remember all kinds of drugs and how these different kinds of drugs, which are classified under antihypertensive drugs, work in our body. Always remember, angiotensinogen present in blood gets converted to angiotensin 1 by renin. Now, angiotensin 1 gets converted to angiotensin 2 by a converting enzyme called angiotensin converting enzyme, which is a kinase 2 enzyme. Now, angiotensin 2 vasoconstricts, and also it helps in secretion of aldosterone. Now, both of them increase peripheral vascular system and increase sodium and water retention, which increases blood pressure. Now, angiotensin converting enzyme also helps in degrading of bradykinin to inactive metabolites. Now, if this angiotensin converting enzyme is somehow decreased, then we can see the kininogen gets converted to bradykinin by kallikrein, and bradykinin increases prostaglandin synthesis, which leads to vasodilation and decreased peripheral vascular resistance and decreased blood pressure. So, this is how by renin inhibitors or angiotensin AC inhibitors we can control our blood pressure. Now, here are a few points that you should remember always. The AC inhibitors, such as enalapril or lisinopril, are recommended when preferred first-line drugs. Diuretics or beta blockers are contraindicated or ineffective. Actions: the AC inhibitors lower blood pressure by reducing peripheral vascular system without reflexively increasing cardiac output. That is mostly very important thing, that it doesn't have reflexive tachycardia or contractility. These drugs block the AC that cleaves angiotensin 1 to form the potent vasoconstrictor angiotensin 2 and breakdown of bradykinin. These are the two ways which I have earlier discussed. We should always remember among the mechanism. By reducing the circulating angiotensin 2 levels, we also decrease the secretion of aldosterone, resulting in decreased sodium and water retention, which again, if there is increased sodium and water retention in our body, it will increase our blood pressure. Now, AC inhibitors, among different therapeutic effects, we have also adverse effects. The adverse effects are dry cough, hyperkalemia, skin rashes, hypotension, fever. Now, hypotension reason you can understand, because if there is increased amount of AC inhibitors in our body, and if we take increased amount of AC inhibitor in our body, we are decreasing blood pressure, but we may also decrease the required levels of blood pressure that in the body and lead to hypotension. And otherwise, we have potential hyperkalemia, like as you can see from here. The potassium levels must be monitored and potassium supplements or spironolactone are contraindicated, because you can see AC inhibitors lead to hyperkalemia. The next class of drug is angiotensin 2 receptor antagonists. As I have already shown you the mechanism of angiotensin 2 receptor antagonist. The angiotensin, I will discuss this thing. The angiotensin 2 receptor blockers are alternatives to the AC inhibitors. Losartan is the prototypic ARB. Currently, there are 6 additional ARBs. Their pharmacological effects are similar to those of AC inhibitors in that they produce vasodilation and block aldosterone secretion, thus lowering blood pressure and decreasing salt and water retention. ARBs also decrease nephrotoxicity of diabetes, making them an attractive therapy in hypertensive diabetes. This is the main important thing, one of the major stuffs that why we use ARBs in hypertensive diabetes. Their adverse effects include similar to those of AC inhibitors, although the risks of cough and angioedema are significantly decreased. They are ferrotoxic. Always remember this. Now, the second class of drug is direct renin inhibitor, and that is aliskiren. As you can see, renin helps in conversion of angiotensinogen from angiotensin 1. Aliskiren by inhibiting renin again decreases levels of angiotensin 1 and angiotensin 2. It is useful in hypertension combination with diuretics, ACE inhibitors or ARBs. Increase antihypertensive efficacy. It is administered orally. Adverse effects include diarrhea, abdominal pain, headache, angioedema. I would like you to remember mainly adverse effects of angiotensin receptor. I would mainly like you to remember the adverse effect of ACE inhibitors rather than adverse effects of angiotensin 2 receptors antagonist or renin inhibitors, because that's what comes in exams much more than the adverse effect of these drugs. Now, there is also a role of diuretics in controlling blood pressure of our body. Now, diuretics, uh, we will be discussing about diuretics. One of my colleagues will discuss diuretics in the upcoming videos of pharmacology of renal system. But still, it is one of the main drugs in CVSs. We should be having. We should be touch. I am touching this topic for you. Uh, Now you have seen that among diuretics we have seen the action of thiazides. Thiazides were listed in the chart that I had given you previous slide. Now, the mechanism of action of thiazide. Thiazide, they inhibit sodium chlorine symport in the early part of the DCT, which and promote sodium and H2 excretion, which again decreases cardiac output, decreases blood pressure, decreases peripheral vascular resistance, and in turn decreases. Now the mechanism of thiazides can be described here, like thiazides inhibit sodium chlorine symport in the early part of DCT. They promote sodium H2 excretion, which on chronic therapy can lead to decreased sodium concentration in vascular smooth muscles, and that can lead to decreased peripheral vascular resistance, which decreases blood pressure. And also by H2 excretion and sodium excretion, cardiac output also decreases, and blood pressure in turn also decreases. Advantages of thiazides can be listed here. They have long duration of action, they are cheap, well tolerated by elderly patients, decrease in incidence of fracture in elderly patients by reducing urinary calcium excretion, have synergistic effect when used in combination with other antihypertensive drugs. Chlorthalidone is frequently used thiazide diuretic in hypertension, and it has long duration of action. Indapamide and metalozone are more potent, longer acting, and produce fewer adverse effects than thiazides. As I've again said, there is also loop diuretics, but I won't go into much of the details because it will be discussed later on in other video by one of my colleagues. Now coming to the next part, we have calcium channel blockers. Now CCBs are recommended when the preferred first line agents are contraindicated or ineffective. They are effective in treating hypertension in patients with angina or diabetes. High doses of short-acting CCBs should be avoided because increased risk of myocardial infarction. Classes of calcium channel blockers can be listed below. These are verapamil, diltiazem, and dihydropyridines like nifedipine, amlodipine, felodipine, istradipine, nicardipine, and nisolodipine. Now, we will be discussing about the actions and uses of calcium channel blockers. Now, calcium channel blockers block the inward movement of calcium by binding to L type of calcium channels. This is most important. L type of calcium channels in the heart and in smooth muscle of the coronary and peripheral vasculature. This causes vascular smooth muscle to relax, dilating mainly arterioles. Therapeutic causes. Now, therapeutic uses of calcium channel blockers are they have intrinsic natriuretic effect and therefore do not usually require the addition of a diuretic. These agents are used in treatment of treatment of hypertensive patients who also have asthma, diabetes, angina, and or peripheral vascular diseases. Black hypertensive patients respond well to calcium channel blockers mostly. Most of these agents have short half-lives. Treatment is required 3 times a day to maintain good control of hypertension. Now, as we have seen, calcium channel blockers can be divided into dihydropyridines and non-dihydropyridines. So, I would like to discuss on dihydropyridines. Dihydropyridines include nifedipine, amlodipine, felodipine. It's like any drug with last dipine in their name. It can be like nifedipine, amlodipine. We can classify it under dihydropyridines. These new generation calcium channel blockers differ in pharmacokinetics and drug interactions. All dihydropyridines have a much greater affinity for vascular calcium channels than for calcium channels in heart. They are therefore particularly attractive in treating hypertension patients. Newer agents such as amlodipine and nicardipine have the advantage that they show little interaction with other cardiovascular drugs such as digoxin or warfarin, which are often used concomitantly with calcium channel blockers. Now, dihydropyridines are verapamil. It is the least selective of any CCB and has significant effects on both cardiac and vascular smooth muscle cells. It is used to treat angina, supraventricular tachyarrhythmias, and migraine headaches. Diltiazem is another non-dihydropyridine which affects both cardiac and vascular smooth muscle cells. However, it has a less pronounced negative inotropic effect. Inotropic effect is about effect on size of the heart compared to that of verapamil. Diltiazem has favorable side effect profiles. Now, adverse effect of CCBs. Adverse effects of CCBs are constipation, vertigo, headache, fatigue, and hypotension. Hypertension, one of the most common adverse effects of any antihypertensive drug, but here it is other than hypertension, we have constipation, vertigo, headache, fatigue. Now, another class of drugs that we are going to discuss is beta adrenoreceptor blocking agents. Beta blockers are currently recommended as first-line drugs for hypertension when indicated, for example, with heart failure. Actions are the beta blockers reduce BP primarily by decreasing cardiac output. They may also decrease sympathetic outflow from CNS and inhibit the release of renin from kidneys, thus decreasing the formation of angiotensin 2 and secretion of aldosterone. Prototype beta blocker is propranolol, which acts at both beta 1 and beta 2 receptors. Selective blockers of beta 1 receptors, such as metoprolol and atenolol, are among the most commonly prescribed beta blockers. The selective beta blockers may be administered cautiously to hypertensive patients who also have asthma, for which propranolol is contraindicated due to its blockade of beta 2 mediated bronchodilation. Now, as you can see, as I have put in this picture, beta adrenal blockers, they control hypertensive patients by decreasing the activation of beta 1 adrenal receptors on heart, decreasing in renin, and decreasing in sodium water retention. Decreasing of activation of beta 1 receptors on heart will decrease cardiac output. Decrease cardiac output. Decrease in renin will decrease in angiotensin 2, peripheral resistance decrease, and aldosterone will decrease. Sodium water. Now, as you have seen in beta adrenal receptor blockers, by administering beta adrenal receptor blockers, we are decreasing activation of beta 1 receptors on the heart and decrease in renin. Decreasing of activation of beta 1 receptors on the heart will decrease uh, cardiac output, which will decrease in blood pressure. Decrease in renin will decrease angiotensin 2, that will decrease aldosterone, which will in turn decrease sodium and water retention, blood volume, peripheral resistance, and this will decrease blood pressure in total. Now, what are the therapeutic uses of beta 1 adrenal receptor blockers? The beta blockers are orally active. They take several weeks to develop their full effects. They are more effective for treating hypertension in white than black patients and in young compared to elderly patients. Conditions that discourage the use of beta blockers, for example, severe chronic obstructive lung disease, chronic congestive heart failure, or severe sympathomatic occlusive peripheral vascular diseases are more commonly found in elderly and in diabetics. Hypertensive patients with concomitant diseases, the beta blockers are useful in treating conditions that may coexist with hypertension, such as supraventricular tachyarrhythmia, previous myocardial infarction, angina pectoris, chronic heart failure, and migraine headache. Adverse effects of beta blockers include hypotension, as again, bradycardia, because they are acting on beta 1 receptors of heart, fatigueness, insomnia, and sexual dysfunction. Another class of drugs is centrally acting adrenergic drugs. Among centrally acting adrenergic drugs, we will be discussing about clonidine and methyl dopa in particular. Clonidine is an alpha 2 agonist which diminishes central adrenergic outflow. Clonidine is used primarily for treatment of mild to moderate hypertension that has not responded adequately to treatment with diuretics alone. Clonidine does not decrease renal blood flow or glomerular filtration and therefore is useful in treatment of hypertension complicated by renal disease. Very, very important. Because it causes sodium and water retention, clonidine is usually administered in combination with the diuretic. Side effects include sedation, drying nasal mucosa. As you can see, it is a very mild side effects. Rebound hypertension occurs following abrupt withdrawal of clonidine. Now you can see clonidine stimulates alpha 2 receptors in vasomotor center, which decreases sympathetic outflow from vasomotor center, and it affects the heart and blood vessels. In heart, it will decrease heart rate, cardiac output, which will in turn decrease blood pressure. In blood vessels, peripheral vascular resistance will decrease and blood pressure will in turn will decrease. Alpha methyl dopa is again an alpha 2 agonist converted to methyl norepinephrine centrally to diminish the adrenergic outflow from CNS, leading to reduced total peripheral resistance and a decreased blood pressure. Cardiac output is not decreased and blood flow to vital organs is not diminished. Because blood flow to the kidney is not diminished by its use, alpha methyl dopa is especially valuable in treating hypertension patients with renal insufficiency. Side effects, sedation and drowsiness. Now, mechanism of alpha dopa is given, then it gets converted to alpha methyl dopamine. Alpha methyl dopamine gets converted to alpha methyl noradrenaline, which stimulates alpha 2 receptors on vasomotor center, which decreases central sympathetic outflow. Heart rate, peripheral vascular resistance decreases, and in turn, blood pressure decreases. Now we have alpha adrenergic blockers. I won't be discussing it in details because it has already been covered in uh, videos on autonomic system pharmacology by one of my colleagues. But still, alpha blockers can be divided into non-selective blockers, alpha 1 and alpha 2, which act on both alpha 1 and alpha 2 receptors, and selective alpha 1 blockers. Among non-selective alpha 1 blockers, we have phenoxybenzylene, phentolamine, which block both alpha 1 and alpha 2 receptors in blood vessels. vasodilation will be caused and fall in BP, and there will be huge increase in noradrenaline release due to presynaptic alpha 2 blockade. Tachycardia, which is one of the most adverse effect, is very much prominent. Now in alpha 2 alpha 1 receptor blockers, we have and prazosin and terazosin. Prazosin blocks selectively alpha 1 vascular receptors by competitive mechanism. Vasodilation and fall in BP is seen. Alpha 2 receptors are not blocked, hence there is no increase in level of noradrenaline. Therefore, tachycardia is very much minimal. So, this adverse effect can be avoided by giving prazosin. So this makes very important drug for antihypertensive patients. Hypertensive patients. Now the next class of drugs is vasodilators. Direct acting smooth muscle relaxants are hydrolyzing and minoxidil. Vasodilators produce relaxation of vascular smooth muscles, which decreases resistance and therefore decreases blood pressure. These agents produce reflex stimulation of the heart, resulting in the competing symptoms of increased myocardial contractility, heart rate, and oxygen consumption. These actions may prompt angina pectoris, myocardial infarction, or cardiac failures in predisposed individuals. Vasodilators are also increase plasma renin concentration, resulting in sodium and water retention. These undesirable side effects can be blocked by concomitant use of diuretic and a beta blocker. So, how does this vasodilators works? The vasodilators like minoxidil diazoxide activate K plus channels. This K plus channel opens and there is K plus efflux. There will be hyperpolarization of vascular smooth muscles. This will lead to vasodilation and this in turn will decrease blood pressure. Now, there are two main vasodilators. They are minoxidil and hydrolyzing. First, minoxidil. This drug causes dilation of resistance vessels, arterioles, as we know, but not of venules. Minoxidil is administered orally for treatment of severe to malignant hypertension that is refractory to other drugs. Minoxidil causes serious sodium and water retention, leading to volume overload, edema, and congestive heart failure. Minoxidil treatment also causes hypertrichosis, growth of body hair. This drug is now used topically to treat male pattern baldness. Well, this is the last line was really interesting, but as you can see, because of so many adverse effects, minoxidil is usually avoided in patients. Now, hydrolyzine is used to treat moderately severe hypertension. It is almost always administered in combination with a beta blocker, such as propranolol, to balance the reflex tachycardia and a diuretic to decrease sodium retention. Together, the three drugs decrease cardiac output, plasma volume, and peripheral vascular resistance. A lupus-like syndrome can occur with high dosage, but it's reversible on discontinuation of drug. So again, you can see that hydrolyzed and minoxidil are usually avoided in treating hypertensive patients, but still many people use it due to different reasons. Now the next drug, which is very much important in hypertensive emergency patients, this is sodium nitroprusside. Now sodium nitroprusside, it is administered intravenously. It is metabolized rapidly. Okay, because of half life of minutes, and it is requires continuous infusion to maintain its hypotensive action. It is capable of reducing blood pressure in all patients regardless of the cause of hypertension. Acting equally on arterial and venous smooth muscles, it can reduce cardiac preload. Adverse effects: hypotension caused by overdose, nitroprusside metabolism results in cyanide ion production. Although cyanide toxicity is rare, but it can be effectively treated with an infusion of sodium thiosulfate to produce thiocyanate, which is less toxic and is eliminated by kidneys. This is very important, just remember it. Now, mechanism of action of sodium nitroprusside. Sodium nitrogen when given to body, it generates nitric oxide, which relaxes vascular smooth muscles. There will be vasodilation, and venodilator. It will be leading to pooling of blood in veins, decrease in venous return, decrease in preload, decrease in cardiac output, decrease in blood pressure, and as an arterial dilator, decrease in peripheral vascular resistance, decrease in afterload, and decrease in blood pressure. So you can see sodium nitroprusside is very effective as an antihypertensive drug, but again, overusing of it, which is called most of the times, can lead to hypotension. So it should be judiciously used. Now there is a condition where there is hypertension emergency. Now hypertension emergency is a very rare but life-threatening situation in which the diastolic blood pressure is either more than 150 millimeter of mercury with systolic blood pressure more than 210 millimeter of mercury in an otherwise healthy person, or a DBP of more than 130 millimeter mercury in an individual with pre-existing complications such as encephalopathy, cerebral hemorrhage, left ventricular failure, or aortic stenosis. The therapeutic goal is to rapidly reduce blood pressure, and it can be done by giving sodium nitroprusside, labetalol, phenoldepam, or nicardipine. Now the treatment schedule is given here. This is onset of action, duration of action. Firstly, immediately within 1 to 2 minutes, nitroprusside should be given. Then after that, labetalol, phenoldopam, nicardipine. Hypertension emergency is a very important topic, and I will suggest you to read it from your book. Either I will prefer to read it from KDT, but if it's not possible, you can give a read of Shanbach. The topics are very lucidly presented there, but yeah, the lack of color makes it little dull to study. But maybe you need to study that.